Hi everyone, Jennifer Blevins-Smith with Integral Clinic Solutions, and you're watching my YouTube channel, Navigating the Business of Medicine. Today we're going to talk about the purpose behind taxonomy codes. I have another video where I talk about what a taxonomy code is, and I will just briefly review that today, but I really want to focus on the purpose of taxonomy codes and the reason why you need to keep taxonomy codes as accurate and up to date as possible. Taxonomy codes are maintained and created by the National Uniform Claim Committee. A lot of us call it NUC, NUCC for the acronym in healthcare. They have a website that you can go to and you can look up taxonomy codes. You can look it up by classification, you can look it up by starting to type some numbers, you can put in a description, I believe. It's been a while since I've been on the website, but it will help you try to find the most accurate and close taxonomy code to you. Taxonomy codes help payers with understanding, I have it written down because I wanted to get it right, the provider's type, classification, and specialty area. So it gives 3 different criteria, data of information in this 10-digit code. It is 10 digits, it's alphanumeric. You have probably seen them before. If you don't know what I'm talking about, I'm sure once you Google taxonomy codes and you see how it is, you'll be like, oh, that's what it is. It's on some claims. Some insurances require taxonomy codes to be included on claims. Many do not. However, I know Medicaid is a big one that does. You do need to put both the rendering provider's taxonomy code and the billing provider's taxonomy code on claims. The purpose of this is to make sure that the services being billed and that were offered to patients or conducted, I guess, are appropriate for the practice and the provider in which provided these services. It's very, very important. So let me back up. Taxonomy codes are assigned to individual NPI-1 numbers. So all providers have a taxonomy code associated to their NPI, as well as groups and medical clinics, things like that. When you get a contract and an NPI-2 number, you also have taxonomy codes. The taxonomy code for the NPI-1 with the provider does not have to exactly match that of the group. However, the group's taxonomy code or codes, because you can have more than one, needs to mix together. They need to fit, right? So a lot of groups will have a multi-specialty taxonomy code because they have and offer services with different specialty providers in their group, which makes sense. You have a multi-specialty group, you have the taxonomy code to match, you have providers that are dermatology, primary care, internal med. You have a mix of specialties in that group. So that works, okay? You can assign more than one taxonomy code to a group and to an individual. You do not just get one and done. You can have 2, 3, 4. I've seen 4, depending on how specific and subspecialty a provider is. You know, they might be in some very, very unique situation where they have internal med and then they have surgery and then they have abdominal surgery and then they might have, you know, something even more subspecialty. That's totally common. Same with groups. You might have 2 or 3 different taxonomy codes. You always have to pick one primary taxonomy code, which is the first one that would go on your claims. However, a lot of billing systems have abilities to map taxonomy codes differently to different payers depending on how they have you listed. Because when you credential a provider, they ask for the taxonomy codes and they ask for the NPI and they get that all entered in their system. Then you have the same thing when you get a contract for the group and the NPI-2 and taxonomy. All this information is on file at the insurance company and it all needs to match. So the purpose, again, going back to the reason for this video, is when that claim comes in with those procedure codes and the diagnosis codes, the insurance system and the people working these are coming in and going, okay, this provider rendered the services, and they check and make sure the MPI is associated to the group that's getting billed. They make sure that they're credentialed with the insurance, and they check the taxonomy code to make sure that it's in their realm of specialty to bill these specific codes. And they do the same thing for the billing provider or the group that's on the claim. Is this an appropriate provider working at an appropriate group with an associated or affiliated taxonomy code? Are they contracted, etc.? This all gets looked at. I have seen denials for CPT codes being billed by specialists or by providers where the CPT code is not classified in their specialty. And the insurance goes, why are you providing this service? This is not something we consider as a service that you should be offering and performing for our beneficiaries under your taxonomy code. Sometimes you can fight it out and you can make your case and appeal it, and they'll be like, oh, okay, and you get it figured out. Other times you have to eat the cost because they're going to say, no, 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 no. We need a certified whatever it is, or we need this in order to pay for this. You have to check the payer's guidelines. Every insurance is going to have different guidelines. For the most part, it's not this difficult. It's more straightforward and cut and dry. But there are times that this happens, especially when you get into the subspecialties or you get into behavioral health is a big one, right? Because there's many different CPT codes to bill out for different behavioral health services depending on the type of provider that rendered the services. You have counselors, you have social workers, you have psychiatrists. There are so many different things across the board, different providers, different types of things that they can do. And that's where I think most of the denials come in, is that someone just mistakenly uses the incorrect CPT code, not knowing that there's specific codes for different providers in different specialties for these different things. And behavioral health is like the number one thing that comes to my brain on this, because of all of the various different providers that could be involved in a patient's care. So they'd be like, this code. And then you go, oh, shoot, that's actually a code the psychiatrist should have used for a med check or a medication, something, whatever it is, test to see if they qualify for a certain diagnosis or whatever. And you go, oh, I should have used this code. Usually it's an easy fix where you're just replacing the code because a wrong one was used. But there have been times where it was, oops, I didn't know that type of specialist couldn't provide that type of care. It's something you really need to be aware of. You also, like I said, I'm going back to the payer guidelines, the billing guidelines. Some insurances, TRICARE, Medicare, they might say, okay, this provider can provide these services. However, they need to be certified. And maybe there's a taxonomy code that says certified, blah, 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 that needs to be associated to their MPI in addition to their existing taxonomy to allow them to be paid for those services. That's why you have to stay on top of the payer guidelines. You have to reference them, and you have to be comfortable reading and asking questions if you need to, calling the insurance to find out more details if you're not getting what you need. Taxonomy codes can make or break you for a while if you don't get it figured out. One, getting them associated correctly to the right provider in the group so that the insurances are happy on the claims that are submitted. And two, making sure you're billing out the appropriate CPT codes by provider to make sure that they're staying within their specialty and what they can bill. So one of those things, the purpose is for the insurances not only to track and make sure that they're paying providers for the right services and people aren't overstepping their boundaries of what kind of medicine they should be practicing. It also will help with their reporting because they keep data and a bunch of different things that they're tracking to see how many codes are being billed by which specialty and how many, when it comes to credentialing, are on their roster or on their panel under that taxonomy, because we've heard that know the panel's full for that specialty, things like that. It's because they're going off of those taxonomy codes and how many of those subspecialists are in a certain geographical area to how many beneficiaries they have in their area. And they do this whole algorithm and calculation to decide if they want to accept more providers of that specialty taxonomy in that area. It's very, very important to keep taxonomy codes up to date and accurate. It is so easy to change a taxonomy code or add a taxonomy code. You just go on to the NPPES website where providers submit for their MPI numbers, and you go on, you edit whichever one, MPI 1 for individual providers or the MPI 2 for the group. You edit and you can add taxonomy codes. Now, if you're going to be removing taxonomy codes, that's going to be a little bit more difficult because you would need to notify your payers as well, any of them that have the existing taxonomy listed for the group or the provider, because that could cause a lot of issues. However, most times people are going on to add a taxonomy code or correct something that was incorrect, and that makes it a lot easier. But just be mindful of that. Usually, when you change one thing that comes into any kind of credentialing, licensing, certifications, it's probably going to affect other things. So just keep that in the forefront of your mind. If you have any questions or comments about this, please leave that in the comments below. Smash the thumbs up button if today's video was helpful. Subscribe to my channel if you haven't already, and please share this with your colleagues. I hope you're doing well, and we'll see you next time. Bye-bye.